Good morning, everyone. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At the moment, all participants are in a listen-only mode. For those that are connected by telephone requiring operator assistance during the call, please press *0. For those online that require assistance, please use your chat box on your screen. I would like to now hand the meeting over to your host, Carla Thorpe, Director of Prevention and Promotions at Mental Health Commission of Canada. Please go ahead.
Wonderful. Thank you very much. Hello, everyone, and welcome to the Mental Health Commission of Canada's webinar series on suicide prevention. Bonjour et bienvenue à tous. Today, we are very excited to be hosting this particular session, which will focus on alcohol use and suicide, two topics that are often not discussed together despite their connection. So my name is Carla Thorpe. I'm the Director of Prevention and Promotion Initiatives with the Mental Health Commission of Canada. I am hosting this webinar today from my home office, which is located on the traditional unceded territory of the Algonquin people in the Ottawa-Gatineau area. So welcome, everyone, and thank you so much to all of you who have joined us. We've seen quite a diversity of participants who have signed on so far from a number of our health authorities across the country. I've seen some registrants from Alberta Health Services, from Interior Health, from Eastern Health in Newfoundland, and many of you joining today from the various CMHA branch offices as well. So a very warm welcome. And thank you as well to our colleagues from CFHI who are hosting us today on their webinar platform. We're very pleased today to be offering the webinar in both official languages. Today's webinar will be presented in English and will be simultaneously translated into French. You're able to access the French audio by calling the telephone number that's displayed on your screen. And we would welcome you to do that if you would like to listen into the French. If you're having difficulty connecting into the French, you can just use the chat feature as well, and we will try to resolve any technical problems that you have there. You'll also see on your presentation screen today that you'll have the two presentations available, one in English, which is on probably on your left-hand side, and the other one on the right-hand side will be in French. Depending on the size of the screen that you're using today, the font might be quite small, but you are able to expand the presentation and focus just on the language of your choice for today's session if you'd like to view just in a single language. So if you go up to sort of on the right-hand side of the screen, you'll see 4 little arrow boxes that point out in all 4 directions. So that will maximize the screen for either the English or the French version, depending on which one that you would like to view. You will notice as well that we will be using the chat function today for you to ask questions in either English or in French, the language of your choice. And we will have some time at the end of today's presentation to address hopefully as many of your questions as we can get to. I know we're a very large group today, but we would encourage you as we go through the presentations to any questions that you have in mind to add them to the chat feature, and then we will moderate a question and answer session at the end of today's session. Also, if your question is to be directed to a specific speaker, you're welcome to indicate that in the question, or if you have a more general question that you would like to put to our panel of presenters today, then we can address it in that format as well. The other thing that I just wanted to remind people today, just given the topic of the presentations today, and certainly any sessions that focus on topics including suicide can be difficult and present some challenges for people. So we will be adding into the chat feature some distress numbers. If you do need some support, we would encourage you to reach out If there is something distressing that's raised in terms of the content of the session today, we would certainly encourage you to reach out to a local crisis center or distress line for some support if that is required today. So again, a warm welcome to everyone who has joined us. Thank you so much for being here. It's my pleasure now to introduce our speakers who will be joining us for the webinar today. We have a total of 4 people who will be presenting to us in sequence. Firstly, we'll hear from Dr. Heather Orpana, who's a research scientist at the Centre for Surveillance and Applied Research at the Public Health Agency of Canada. Then we will hear from Dr. Sarah Konefal and Dr. Robert Giesbrecht, who are research and policy analysts at the Canadian Centre on Substance Use and Addiction. And finally, we will hear from Dr. Norman Giesbrecht, who's a scientist emeritus at the Institute for Mental Health and Policy Research at the Centre for Addiction and Mental Health, and is also an adjunct professor in the Dalla School of Public Health at the University of Toronto. So with those brief introductions, we will get started with our webinar, and we'll begin the presentation first with Dr. Heather Orpana. So welcome, Heather. Thanks for being here. I will turn things over to you to kick us off with the presentation.
Great. Thank you so much, Carla. So thank you, everyone. I am really humbled to be here today with so many people and organizations across Canada who are interested in this topic, and I want to deeply thank you for your interest in this topic and your presence here. I'm presenting here from my home in Ottawa, and I would like to acknowledge that the land on which I live and work is the traditional unceded territory of the Algonquin people. So today I'm starting off this webinar, and I will give you an overview of how alcohol use is related to suicide, as well as information about the evidence of this relationship in Canada. So, of course, no good work takes place with a single person alone, and I would like to acknowledge my contributors and collaborators who have contributed to the work that this presentation is based on. So we're going to start off just with a little bit of the big picture of suicide in Canada. And I think it's really important that while we're looking at an aggregate of numbers on a slide right now, that each of those numbers is an individual, and so this is a really, really important topic that we're discussing. So each year in Canada, approximately 4,000 people die by suicide, and over the past 10 years, annual mortality has ranged from about 3,800 deaths to 4,400 deaths. This means that between 10 and 12 people per day are lost to this preventable cause of death. And in Canada, the overall suicide mortality rate is about 10 per 100,000. And that puts Canada about in the middle of all OECD countries. In comparison, the United States had a crude suicide mortality rate of about 14 per 100,000 in 2018. When we look at sex, the suicide mortality rate is about 3 times as high among males as among females in Canada. And currently the data we have do not include identifiers for non-binary or transgender identities. However, research suggests among folks who identify as transgender or who have other gender identities, there may be a much higher level of risk for suicide-related behavior and suicide mortality. The rate of suicide is highest among middle-aged males, aged 35 to 64, and it is somewhat similar for females aged 20 to 34 and 34 to 65, who have the highest rates among that population group. So the other topic we're talking about today is alcohol use. And alcohol use is a relatively common behavior among the Canadian population. So about 3/4 of all Canadians 15 years and older living in households reported consuming alcohol in the past year. And about 1 in 6 Canadians reported exceeding the low-risk drinking guidelines for chronic health effects. This is more common among men than among women. And 1 in 9 exceeded the low-risk drinking guidelines for acute health effects, which is also known as heavy episodic or binge drinking. And again, this is more common among men. As well, alcohol use is relatively common among youth, with almost half consuming alcohol in the past year and 1/4 reporting binge drinking. And as we present to you from our homes for the most part, and many of you I'm sure are working from home, we think that alcohol use has changed during the COVID-19 pandemic. This has included changing how we can access alcohol and how we live our daily lives, which may change our drinking habits. So a number of organizations have implemented surveys to understand changes to drinking patterns, and our colleagues from CCSA will also talk about this next. Statistics Canada has monitored changes to alcohol use through the Canadian Perspective Survey Series, which surveys a representative sample of Canadians. In late March, about 1 in 7 Canadians reported an increase in alcohol consumption, while 1 in 11 reported a decrease. And then later, in late April and early May, just under 1 in 5 Canadians reported an increase, while 7% reported a decrease. I think it's also important to note here, not only whether there is an increase or a decrease is important, but also changes to the pattern of people's drinking may have implications for the health and social effects of changes to alcohol consumption. So why are we talking about alcohol and suicide in this webinar? In just a minute, we'll review some of the evidence demonstrating the relationship between alcohol and suicide in Canada. But first, we'll talk a little bit about why alcohol use and suicide are related. So, sorry about that. The perils of working from home. A cat knocked something over. In some cases, alcohol can be the means of poisoning suicide. However, this is actually relatively rare in Canada. Alcohol may also be used along with other substances in poisoning suicide death. And while only one type of poisoning is reported as the primary cause of death, other substances which contributed to the death may be studied through the Vital Stats multiple cause of death data. When we move more upstream, there is relatively good recognition of the role that regular alcohol consumption or alcohol use disorder can play in suicide-related behavior. So disordered use of alcohol can lead to many psychosocial stressors, such as relationship, financial, or employment problems, which can act as stressors that contribute to suicide-related behavior. Alcohol use disorder also frequently co-occurs with other mental disorders, and at least in Western contexts, the vast majority of people who die by suicide are also living with a mental illness. Less frequently recognized, though, is the role of acute alcohol use in suicide. Alcohol use and alcohol intoxication are associated with a number of psychophysiological effects. It can result in impulsivity and poor problem solving. It can lead to aggression, and alcohol is a central nervous system depressant, which can lead to feelings of sadness and despair. So as you can see, the relationship between alcohol and suicide is really multifaceted. It includes biopsychosocial pathways, and it's quite complex. So now that we know a little bit about the pathways connecting alcohol use and suicide-related behaviors, what is the evidence for this association between alcohol and suicide in Canada specifically? My colleagues, including Dr. Giesbrecht, and I conducted a narrative review of the literature on alcohol and suicide, which was published earlier this year in the journal Injury Prevention. And the next slide summarizes these findings as well as additional evidence. In our review, we grouped findings into 3 types of studies: ecological studies, studies reporting alcohol-attributable fractions or deaths, and studies including toxicology results of suicide decedents. So the first type of study we looked at examines the alcohol and suicide relationship at a population level. So for example, these studies may look at average per capita consumption of alcohol and the overall population mortality rate over time. In the early 2000s, Ramstedt found that for every per liter alcohol or increase in alcohol consumption, suicide mortality increased by 4%. And this is consistent with findings from other countries, although the magnitude of this relationship varies. Another study looked at the time series of alcohol sales and suicide mortality rates in combination with the privatization of alcohol sales. And this is important because it increases accessibility to alcohol. Zelkman and Mann found that privatization of alcohol sales was associated with an increase in suicide mortality rate. And finally, Stockwell and colleagues studied private liquor store density, which is also a measure of accessibility to alcohol, and found that for each 20% increase in private liquor store density, alcohol-related deaths increased by 3.25%. Based on their study, over 5 years, approximately 612 suicide deaths were attributable to alcohol use in British Columbia. So while ecological studies support a relationship between alcohol consumption and alcohol sales and suicide rates, these types of studies are relatively weak evidence because they study the relationship at a population level. So the next type of study we summarized reported on attributable fractions or attributable deaths. Technically, an attributable fraction is the percentage of an outcome of the population that would be prevented if the exposure was removed or was present at an ideal level. And in this case, it would be the percent of suicides that would be prevented if alcohol consumption was at 0, which is considered to be the lowest level of risk for the alcohol-suicide relationship. Attributable fractions are calculated by drawing on evidence from a number of sources. We need to know the level of alcohol consumption in the population as well as the level of the outcome in the population, and we saw those earlier in this presentation. We also need to know an estimate of the relationship between the risk factor and the outcome, in this case the relative risk of suicide based on level of alcohol consumption. So from our review, there were 9 publications from 1992 to 2005, and based on these studies, approximately 1/4 of all suicide deaths were alcohol attributable. However, there are actually some more recent estimates that were not included in our review, but have been published recently, and so I wanted to present those to you today. So here you see a chart that presents results from CCSA's Canadian Substance Use Cost and Harms Tool. Along the horizontal axis, you can see the number of suicide deaths, and along the vertical axis, you can see the year. Actually, flip that, my apologies. You can see that in 2017, there were about 1,300 suicides that were alcohol attributable, which was out of a total of about 4,100 suicide deaths, or about 30%. On this next slide, sorry, I'm having a computer. There we go. So here you can see the alcohol attributable suicide deaths for Canada from the Global Burden of Disease Study, which is led by the Institute of Health Metrics and Evaluation at the University of Washington. And for full disclosure, I sit on the scientific council of the study. Here you can see that in 2017, the Institute for Health Metrics and Evaluation estimated that there were approximately 1,100 suicide deaths related to alcohol, or about 26%. So the differences between the CCSA and the IHME estimates are likely due to a difference in methods, either choice of the alcohol estimate, choice of the relative risk curve for alcohol and suicide, or choice of how to calculate the attributable fraction. Regardless, though, pretty consistently across time, we're seeing that researchers estimate about 1/4 to 1/3 of suicide deaths in Canada are alcohol attributable. So the final type of studies that we summarized were studies with results from toxicology analysis. So toxicology analyses may be conducted by coroners or medical examiners while they are investigating a death that is suspected to be by suicide in order to better determine the underlying cause of death, manner of death, and contributing causes. As I mentioned earlier in this presentation, alcohol poisoning is a means of suicide, but it is relatively uncommon, with about only 10 to 20 suicide deaths per year being by alcohol poisoning. However, alcohol can also be a substance contributing to poisoning death by another substance. This type of information, though, is only available from coroners and medical examiners' records or from the multiple cause of death file from Statistics Canada. So you can see that we examined the results of 18 studies published between 1998 and 2018. And it's really important to know that these studies were very variable. They included a range of sample sizes, different age groups, a wide range of geographies across Canada, and different populations focus. And because of the variability in the study populations, we were unable to provide a summary measure of the proportion of suicide decedents who had positive blood alcohol at the time of suicide death. And moreover, because throughout the study period there were not consistent protocols in place, not all decedents had alcohol toxicology available. So this means that any reported prevalence of positive blood alcohol at the time of death is a minimum level. Nonetheless, even with these limitations, positive blood alcohol was identified among a substantial proportion of suicide decedents. In many studies, 1/3 to 1/2 of those who had toxicology results available also had a positive blood alcohol level. And this includes any blood alcohol levels at an impaired level, and in some cases, blood alcohol levels that would be lethal. It's also important to remember that among many of the studies, multiple substances were present at the time of death. So overall, what did we find through our review of the literature? Certainly, all three studies show that there appears to be an important association between alcohol use and suicide death in Canada. However, we still need to have better information about alcohol use at the time of death, and this could be bolstered by systematic documentation of suicide death, including toxicology protocols with blood alcohol levels among all of those who are suspected of dying by suicide. And this would really help to contribute to a better understanding of the role of acute alcohol use in suicide in Canada. Future research on attributable fractions really requires us to better characterize the relationship between different patterns, frequency of use, and duration of alcohol use and suicide death. And for ecological studies, these can be strengthened through using a natural experiment approach, which can examine changes in alcohol policies that affect accessibility and availability and subsequent suicide deaths at a population level. So that's what we can do to improve the research on alcohol and suicide in Canada. But I think most importantly, and why I'm so grateful that you're all here on this call today, and I'm sure that all of you know this much better than me, but it's so important for those who are working in suicide prevention to be aware of the relationship between both longer-term use of alcohol, alcohol use disorder, and even the acute use of alcohol and suicide death. So the WHO recommends that preventing and reducing the harmful use of alcohol, as well as appropriate treatment for those experiencing alcohol use disorder, are universal and indicated suicide prevention interventions. I think if we can all keep the role of alcohol in mind across our various suicide prevention activities, from data to research to prevention, intervention, and prevention, we'll be able to further advance reducing the impact of suicide in Canada. Thank you so much for your attention to this important topic, and I very much look forward to our discussion where I know I'm going to learn so much from each and every one of you. And I'll pass it back to you, Carla.
Wonderful. Thank you so much, Heather, for kicking us off today with the presentation. I'll remind everyone as well that we will be taking questions at the end of the presentations today, but you're welcome to type those into the chat box if you do have some questions. I know a number of people have asked whether or not we'll be sharing copies of the presentation slides with the group, and yes, we will make sure that everyone gets a copy of the presentations from today. And people have been asking and answering already some of the questions that are posted in the chat, but we'd welcome you to continue to post questions there. If you do have some for Heather, we can get to those afterwards. But first, we will move on to our next presentation. We'll turn things over to Sarah from the Canadian Centre on Substance Use and Addiction for our next presentation. So Sarah, over to you.
Thanks, Carla, for the introduction. And thank you, Heather, for a really good start to the presentation as well. So Rob and I will be talking about two data sets that speak to different aspects of alcohol and suicide. And I'll just add that Heather's presentation was a really good overview and was kind of at the level of the forest. And I'll just say in advance that my presentation zooms in on some of the leads. So to start our presentation, actually, we have a few slides to increase awareness about the stigma associated with substance use and addiction broadly, and to recognize the impact of the language we use when talking about substance use. So stigmatizing language often equates identity with substance use or makes it sound like a substance use disorder is a person's fault. Some examples of this are on the slides here. And at CCSA, we encourage the use of person-first language. Some examples here on this slide that also focus on the medical nature of substance use disorders and change the way we view people who use substances. So here's some more examples of how we can change our language to reduce the stigma around substance use and addiction. And in the interest of time, you'll see that I've moved very quickly to the main portion of my talk, because I think I have just about 10 minutes, which is about alcohol-related intentional poisoning deaths. So as a bit of background, the data set that I'll be talking about was initially part of another project at CCSA that Heather referred to, where we estimated the cost of harms associated with substance use, including a variety of harms that were either wholly or partially attributed to substance use, and then broken down by these categories. The study also estimated the total number of deaths attributable to substance use across the drug categories. And so here I'm just showing a slide that has the total estimates for 2015 through 2017. And you can see alcohol on the left there. And so these total estimates include deaths that are attributable to intentional and unintentional poisoning. So to estimate poisoning deaths attributable to suicide, which I'll be referring to as intentional poisoning, we use the Canadian Vital Statistics Death Database. As mentioned previously, this collects demographic and medical information, including the cause of death from provincial and territorial registries. It includes Canadian residents and non-residents, and the registration of death is completed by either a medical examiner or coroner. So data from 2014 to 17 was stratified by sex, intent, and the combination of substance classes. So we know that, as mentioned previously, many poisoning deaths involve more than one substance. So the data set includes records for which multiple substances contribute to the cause of death. And the substances that are included are alcohol, depressants, cocaine, opioids, and other stimulants. And all unique combinations are counted separately. And I'll just reiterate that we're only looking at poisoning deaths and not suicide deaths due to other causes. So the deaths are coded according to the International Classification of Disease Codes. As I mentioned, multiple causes of death can be identified, or multiple substances. So for intentional poisoning deaths, these are considered to be self-harm and or suicides. And essentially, alcohol can be coded as either the underlying cause of death or a contributing cause of death if multiple substances are involved. And so finally, just some important limitations to consider about the data set. So first, we're excluding poisoning deaths that are classified as unintentional or accidental. The data set also excludes poisonings with undetermined intent. The identification of alcohol as a contributing cause of death does depend on toxicology screening, and this can be imperfect. And some fraction of fatal poisonings coded as unintentional or undetermined are actually thought to be suicides. And so it's thought that suicide rates because of this, are underreported by about 10%. And so moving on to the data. So here are the total counts of intentional poisoning deaths involving alcohol between 2014 and 17, which range between about 100 to 120 per year. So if you remember from Heather's presentation, the total number of alcohol attributable suicide deaths was about over 1,000 in 2017. So the poisoning deaths here are only making up about less than 10% of the total. So the other thing you'll notice is that a substantial proportion, about 60% of intentional poisoning deaths involving alcohol, also involve at least one other substance. And this is just breaking that out by sex, so for males and females. And I have a couple bullet points here, but I'm going to skip over them quickly because essentially there's no statistical significance between the proportions of alcohol only or alcohol and other substances that make up the total number. And the other thing is that there are slightly higher counts among males. And so I'm going to move on to the next slide, which looks at how alcohol compares to the other substances that we examined. And so here's a chart that shows the proportion of alcohol-related poisoning deaths in pink there among all intentional poisoning deaths. So across the years, alcohol consistently makes up about 20% of intentional poisoning deaths after opioids, which are at about 44%, and depressants at about 33%. And so this is among poisoning deaths where only one substance category is determined to contribute to the immediate cause of death. And if we look at the total number of intentional poisoning deaths where more than one substance contributes to the cause of death, so I've referred to these as polysubstance poisonings. Alcohol makes up about half of all of these deaths, and this hasn't changed significantly over the time frame of 2014 to 17. Taking the last two slides together, if we look at all intentional poisoning deaths, so those that involve only one substance and those that involve more than one substance, alcohol causally contributes to about 1/3 of all intentional poisoning deaths. And in 2017, about 18% of these deaths involving alcohol were among males and 13% were among females. So I think I only have a couple minutes left of my slot here. So I'm not going to go into the next two slides in much detail, but essentially, so here I'm just showing the crude death rates for the combination of different substances contributing to poisoning deaths. And essentially, they're just to show that among the polysubstance poisoning deaths, combinations of alcohol with either depressants or opioids are the most frequent, and this is the same for both males that are shown on this slide and females on this slide. So to summarize all those colorful bar charts, really this data set essentially speaks to the significant contribution of the acute use of alcohol to suicide in general, and also in comparison to other substances that are known to be means of intentional poisoning. And to recap the data, 1/3 of all intentional poisoning deaths involve alcohol. About 60% of those involve other substances, usually opioids and depressants. And 50% of the polysubstance poisoning deaths involve alcohol. And finally, I just have some brief comments about what this sort of data set could mean for policy and practice. So this can provide meaningful information to inform prevention and intervention activities, even though there are important limitations to consider for how the cause of death is determined. And the data set most notably identifies a polysubstance factor to consider when thinking about alcohol as a means of suicide, and this is consistent with other research showing, for example, that concurrent use of alcohol and other substances does increase the odds for suicidal behaviors. And so that concludes my 10-minute portion of the CCSA talk. So I'll introduce my colleague Rob, who works on several, who's the next speaker, and he works on several projects about substance use and mental health, usually with a particular focus on cannabis, but this year he's leading several projects looking at the impacts of COVID on substance use. So I will pass it on to Rob.
Thanks, Sarah, and hello, everyone. For my part of the webinar, I was asked to present an overview of how alcohol use has changed over the pandemic. And to do so, I will be speaking mostly to some of the data that we had collected back in April and May. But before starting, I just wanted to mention one important point. There have been a number of surveys assessing alcohol use during COVID, and they all seem to be showing slightly different numbers. And this is partly because the study design is different across study, and this includes how the question, how has your alcohol use changed during COVID, has been asked. But a bigger difference between surveys is in who's been asked the question. So for example, some surveys asked about alcohol use to both those who use alcohol and those who do not. And in these surveys, the percentage of individuals reporting an increase and a decrease in alcohol use has generally been lower compared to other studies. By contrast, some other surveys have asked about alcohol use to only those who use alcohol, and therefore in these surveys, the percentage of individuals indicating an increase and a decrease in alcohol use has generally been higher. So that's just something I wanted everyone to keep in mind while interpreting the data that I will be presenting shortly and the data from other surveys out there. So the data that I will be speaking to today comes from two NANOS polls that we commissioned early on in the pandemic. The first one was conducted in late March and early April and assessed both alcohol and cannabis use, while the second was conducted in late May, focusing strictly on alcohol. And both reports can be found on our website at ccsa.ca. One important point that I did want to highlight on this particular slide is that the data that I will be presenting in the subsequent slides is only among individuals who reported staying at home more due to COVID. So that's one major difference compared to some of the other surveys that are out there. So back in April of this year, early on in the pandemic, we found that most individuals, or about 80%, indicated that they had either decreased their alcohol use or that it had remained the same. But we did find that 18% were reporting an increase in alcohol use, and this was particularly the case among individuals between the age of 35 and 54. And among this age group, it was 25% who indicated that they had increased their alcohol use. In April, we found that a lack of regular schedule was cited as the top reason for increasing alcohol use. And this might not be entirely surprising given that this was obviously a big adjustment period for many of us, where the lines between weekday and weekend and work and leisure were somewhat blurred. And of course, stress was another important predictor of increased alcohol use during this time as well. By contrast, lack of social gatherings turned out to be the top reason for decreasing alcohol use, and of course, health was another important reason. In the second nano study that we conducted in late May, we dug a little bit deeper into both the frequency of alcohol use and the quantity of use during the pandemic. So as shown in the top bar, 25% of individuals reported increasing their frequency of alcohol use in late May compared to pre-COVID times. So this is slightly about 3% of an increase from the data that I showed in the previous slide showing April. However, as shown in the bottom bar, we found that relative to April, 9% reported increasing their frequency of alcohol use in late May. So we were seeing a slight progressive increase in alcohol use over the first few months of the pandemic, which was generally consistent with other surveys assessing this topic. That being said, as we could see in the darker blue portions of the bars, most individuals continue to either decrease their alcohol use or keep it the same. Interestingly, so in the previous slide, I showed that lack of regular schedule was the top reason for increasing alcohol use. However, in May now, the top reason became stress. So it seemed that as the pandemic progressed, stress was becoming a more important predictor of alcohol use. And in May, health now became a more important reason for decreasing alcohol use, whereas in the month previous, in April, lack of social gathering was the #1 reason at that time. So this slide probably looks almost identical to the one that I previously showed, and in many ways it is. So the last slide that I showed was on the frequency of alcohol use, and this particular slide shows the quantity of alcohol use and how that has changed in May. So again, we were seeing a slight increase in the proportion of individuals who were increasing their quantity of alcohol use over time, although most continue to either decrease their use or keep it the same. And again, stress was the top reason for increasing quantity of alcohol use, whereas health was the main reason for decreasing use. So in the May Nanos poll, in addition to asking people about whether their alcohol use has changed since the onset of COVID, we also asked them about how often they were drinking over the past several weeks while at home more because of the pandemic. And these data are shown in this figure here. So according to the Canada's low-risk drinking guidelines, it is recommended that individuals take at least 1 day a week off from drinking to avoid developing a habit. And however, in this figure, we could see that 21% of individuals were actually exceeding these guidelines. And finally, this slide shows how many drinks per occasion people were having while at home more during COVID in May. And I wouldn't really be too concerned about the data points in here. It's just to give you an idea of the distribution of responses that we found. The important part is actually just in the bubble here on the right. So according to Canada's low-risk drinking guidelines, it is recommended that women consume no more than 2 drinks per occasion, and that men consume no more than 3 drinks per occasion. So according to the low-risk drinking guidelines, and these data, 12% of men and women were exceeding the guidelines for short-term harms, which includes increased risk of injury or acute illness, and 19% of women were exceeding the LRDGs for long-term harms, which includes increased risk of liver disease and some forms of cancer. So to sum up, in early stages of the pandemic, most individuals were reporting that they had either decreased their alcohol use or that it hasn't changed. But we did see that around 20% were reporting that they had increased their use of alcohol. And you're probably wondering, since I only presented data up until May, what has happened since? So with the exception of the slight increase in the early months of the pandemic, the numbers have been pretty consistent over time. So for example, in a recent study that we just completed and we just finished collecting the data on, we found that about 22% of individuals were still reporting an increase in alcohol use. So it seems that back from March up until now, it's been on average around 20% that continue to indicate that they're increasing their alcohol use. But beyond knowing that that the use of alcohol is generally increased among individuals who are younger adults, so under the age of 35, and those experiencing poor mental health, we know very little in the way of who has increased their alcohol use and why they have increased their alcohol use. And this is currently an important area of research that is being explored. Another important point is that we also need to better quantify what is meant by increase. So for example, when a person says that they have increased their alcohol use, does that mean that they are now drinking twice a month instead of once a month, or are they now drinking multiple times a week, or is it daily? So that's something that we are working on at CCSA currently to better quantify what is meant by both increase and decrease. So while we don't know the answers to these questions, we do know that a significant proportion of Canadians are exceeding the low-risk drinking guidelines, which among other factors has led to considerable debate over whether or not retail alcohol stores should be considered an essential service or not during a pandemic. So I think that brings us to our first poll question. Okay, so the statement is retail alcohol stores should be considered an essential service during a pandemic. So the options are strongly disagree, disagree, neither agree or disagree, agree, strongly agree, or no vote. So I believe this is happening real time. Okay, so I'm just going to speak quickly to what I'm seeing. So it seems that the most common response is agree, followed by disagree. So we do, just as in the general public, this is somewhat of a polarizing topic. And again, we are seeing that in the data points here. So our second question within this poll is, are you concerned that keeping retail alcohol stores open during the pandemic may increase people's risk for suicide in Canada? So the options here are not at all concerned, slightly concerned, somewhat concerned, moderately concerned, extremely concerned. And here the most common answer is currently slightly concerned. Oh, now it's somewhat concerned. And now there's a tie. Okay, so while everyone continues to vote, I think I'm just going to finish off with one last slide, and then we're going to be turning it over to Norman. So I just wanted to point out that there's a lot of work being done still within this area, and two examples are some of the work that PHAC and Statistics Canada are doing, as well as ours. So, PHAC and Statistics Canada, for example, have launched a large national survey looking at COVID-19 and mental health, and this includes indicators of both alcohol use and suicidal ideation. And CCSA, together with the MHCC, have launched a bi-monthly survey looking at the relationship between substance use and mental health, and how that is changing over time. And we have also included several indicators of suicidal thoughts in our survey as well. So stay tuned for the results, and thank you for your time.
That's great. Thanks very much, Sarah and Rob, to both of you for your presentations. And thanks everyone who participated in the 2 online polls that we launched as well. So we will be moving forward with our next presentation. I would encourage you as well. I've seen quite a few people both asking and answering some questions in the chat box, but if you do have some questions for Sarah or Rob that we can cover at the close of the session, I'd encourage you to enter those into the chat box. But in the meantime, we will move on to our next presentation, and I'll turn things over to Norman Giesbrecht. Over to you, Norman.
Thank you. Can you hear me okay?
Yes, your volume sounds great. Go ahead.
Thank you. I've been asked to talk about alcohol policies and prevention of alcohol-related suicide. There are many different underlying conditions and factors related to suicide, so it is not surprising that there are numerous approaches or pathways to prevention. I would like to acknowledge my co-authors, Elizabeth Parku and Harish Pava. I'd also like to acknowledge Dr. Heather Orpana, Timothy Chow, Amelia Mueller-Williams, and Dr. Emmeline Riesdorfer for their contributions, as well as funding received from the Public Health Agency of Canada. Here are 4 pathways to prevention, and I'm going to speak a bit about each of them and then focus on to alcohol policies. There appears to be much more attention to the third group, whereas the others, more universal in scope, probably are likely more effective at the population level. These could also be called determinants of ill health, disease, and death. I've listed some on the left-hand side. And on the right side are some of the implications and consequences. We'll go back to the previous slide. However, there are some important determinants not noted here that should be highlighted, namely commercial and political determinants, which can have substantial impact on alcohol problems and suicide rates. There has been substantial research on the links between the recession of 2008 and 2007 and 2008 and suicide. And I think that some of this research is also relevant to the pandemic situation. Here are some brief notes on 3 studies that looked at how general economic factors impacted suicide rates. For example, poverty rates during 2007-2008 recession were associated with an increase in alcohol involvement in suicide for men aged 45 to 65 in the U.S. population. Suicide deaths and overdose are related to poverty, poor health care, have been labeled deaths of despair. Shannon Monet has shown that drug, alcohol, and suicide mortality rates are higher in U.S. counties that she looked at with more economic distress and larger working class. Furthermore, international research shows an increase in suicides associated with the recession of 2007 and 2008. However, the increase was not as great in countries with a stronger safety net and such as unemployment protection or sustained welfare spending. And these tended to be the Nordic or Scandinavian countries. Here's a second pathway to preventing suicide, namely controlling access to means and controlling media reporting of means of suicide. 5 general strategies are noted here: controlling firearms, reducing access to lethal prescription drugs, barriers on bridges, bans on hazardous pesticides, and changes in media reporting of suicide. Controlling access to some means seems to have an overall impact on suicide. For example, one study reviewed 18 unique research projects and found that restricting access was associated with a reduction in the number of suicides per year. In Australia, a more effective firearm policy had a substantial impact on reducing suicide, as noted by Large and Nelson in 2010. Grossman, writing about youth suicide, states that families with household firearms should be counseled regarding the risk of firearm injury and death, particularly in the home with an individual with other risk factors. And Whitmute, focusing on the U.S., concludes that evidence suggests that restricting access to firearms for persons with a documented history of alcohol abuse would be an effective violence prevention measure. So one can appreciate that if there's a loaded firearm near at hand and it's not locked away, and a person, let's say, is intoxicated and is suicidal, that it becomes very, very easy to make a very fatal decision. In Sri Lanka, a ban on hazardous pesticides was linked with a sharp drop in suicide rates. It appears that as some means are restricted, not everyone with a suicide intent seeks another option. There are likely many reasons for that, including that a substantial portion of suicides are impulsive. Also, many suicide decisions are made about 1 hour before committing the fatal act. There are several tools and interventions associated with assessment and treatment. 7 are highlighted here with varying degree of effectiveness. It is clear that a combination of measures and interventions are needed in order to reduce suicide rates. However, Eric Kane has identified 5 challenges linked to efforts to reduce suicides by screening and assessment, including these 3. An inability to discriminate the relatively few true cases from the large number of false positive cases, the large number of false negative cases that escape prevention detection, the inability of clinical services to reach many individuals who have suicide intent. Work is continuing on initiatives to increase the accuracy of determining who has suicide intent, when they have it, and how and when to intervene most effectively. Now I turn to alcohol policies. I will highlight just a few studies from a substantial body of research on this topic. Here I have listed 4 reasons why alcohol policies are important. They are universal in scope, and a number of experts have noted that a suicide prevention strategy without a universal component is incomplete and not capable of reaching its full potential. However, as noted here, these policies are underutilized and underappreciated. For example, an analysis that I was involved in 2017 showed that most reviews of suicide prevention initiatives did not even mention alcohol as a risk factor and nor list alcohol policies as an intervention. Here are the main associations among access to alcohol in the top left, alcohol consumption top right, and harm from alcohol, the bottom. These topics have been extensively examined in research going back many decades. So you can see that access contributes to various types of consumption patterns, and this relates to the presentations by Rob and Sarah. And both impact various types of medical, acute, chronic, and social problems, as well as suicide. We have initiated a literature review of the publication on the prevention of alcohol-related suicide over the past 30 years. And here are the research terms and the inclusion criteria. I'm just going to say a few words about this project, which is just underway. We have 845 hits from PubMed, of which 86 were considered to meet the criteria and were relevant to the initiative. Of these 86, there were 10 publications that focused on indigenous youth populations in Alaska and one on the Northwest Territories. These tended to focus on community-level protective factors for alcohol abuse and suicide intention, including, for example, coping skills, positive connection to adults and other elders, community support, and strengthening families. We recently conducted further research and found an additional unique 1,222 abstracts which are currently being assessed. A reasonable projection is that there will be about 200 full papers to consider for data extraction and analysis. As we move forward, these papers will be thoroughly analyzed with plans to submit our findings for publication in 2021. In the next few slides, I sort of overlap a little bit with Heather's presentation. But I think it's important to emphasize that there's an association between alcohol consumption and suicide. There have been a number of studies that examine these trends, and three from Canada. And you can see that Matt Ramstad examined these trends over 50 years and concluded that suicide mortality rates increased 4% for every estimated 1 liter increase in alcohol consumption in the Canadian population. Here are two studies that look at pricing and suicide. As price or tax on alcohol is increased, there's a reduction in suicide mortality. Physical availability is also important. This refers to hours of sale, days of sale, number and type of retail outlets. Here we see that reduced hours were associated with a reduction in suicide. When alcohol sales were privatized in Alberta in 1993, suicide rates increased as shown here. In BC, an increase in private liquor store density was associated with an increase in suicide. Along similar lines, research conducted in Slovenia, Russia, and Belarus showed that harm reduction of alcohol policies were linked with a reduction in suicide, especially among males. In research that I co-authored, we found that the density of off-premise outlets referring to liquor stores and on-premise outlets referring to bars and restaurants was associated with acute alcohol use among 51,000 suicide decedents in the United States. This relationship is illustrated in this slide, especially on the figure on the left. As the number of alcohol outlets per capita is higher, the percentage that are alcohol positive or equal to or greater than 0.08 is also higher. I would like to conclude this part by focusing briefly on two reviews. Here you can see that from 17 studies reviewed, the restrictive alcohol control, is associated with a decrease in suicide mortality. And this systematic review appeared a few months ago. It found that alcohol availability, alcohol pricing, and drink driver countermeasures were associated with a reduction in suicide in the jurisdictions studied. I'd like to now focus briefly on some challenges and recommendations. This slide highlights some challenges for interventions that are universal, selective, or indicated. This is the far left column. In the middle column outlines some examples, and the far right some challenges. For example, those interventions that are effective may not be very popular, looking at the far right column, and those with marginal impact may be popular but costly to implement. So I'm not recommending that any interventions be dropped, but the consideration given to the various types of challenges to implement them effectively. I see there's some notes indicating I'm going too quickly. Sorry about that.
That's okay, Norman. We reminded people that we will be following up and sending them the slides afterwards as well. So if they're wanting to go into more detail, including some of the references, we'll have that material out to them.
Yeah, my apologies. If there's certain slides to go back to, I can do that, or we'll wait till the questions, I guess. Eh?
I think we may as well, in the interest of time, just keep going because we only have a couple more minutes before we open it up for the question and answer period.
Okay. Thank you. The next two slides are based on a project that Tim Stockwell and I led, which assessed the provinces, territories, and federal government on their alcohol policies. The CAPE project, Canadian Alcohol Policy Evaluation Study. You can find all the reports from the CAPE project on www.alcoholpolicy.cisur.ca. I can put that in the chat box later on. This slide highlights some exemplary policies that could be sustained, enhanced, or introduced by the provinces and territories that would be of benefit in reducing alcohol-related suicide. As most of you may know, or many of you may know, it is at the provincial and territorial level where most of the control with regard to alcohol policy is retained. The provinces and territories sort of determine pricing, determine density of outlets, hours of sale, and so on and so forth. So I think many initiatives can be undertaken at the provincial level with regard to alcohol pricing, physical availability, alcohol marketing, advertising controls, brief intervention and treatment, retail control options, alcohol control strategy, monitoring and reporting, and health and safety messages. And in the far right column, I've listed some of the recommendations that would have some benefit with regard to suicide prevention. There are also some concrete harm reduction steps available at the federal level using the similar generic categories as in the previous slide. So here you can see again, it could be pricing, taxing, duty exemptions, protection of government control systems, improving national alcohol strategy based on evidence-based policies, a national monitoring program, and finally labels on alcohol products and health and safety messaging. There's also some very important initiatives that could be undertaken at the local level, as recommended in this slide. While all are important, I would like to highlight three. Brief intervention and treatment, monitoring and reporting, health and safety messaging. All of these provide opportunities for a suicide prevention component. As I've shown, alcohol policies are important in reducing suicide. They are an essential component of a multidimensional suicide prevention strategy that includes all levels and types of government, NGOs, and civil society. Here's my contact information, and thank you for your attention.
Thank you so much, Norman, for your presentation. We're very grateful that you were able to join us today as well. So we're now going to move into our question and answer period. So I would encourage you, if you do have questions, either general questions on this topic or specific questions for some of our presenters, I'd encourage you to type them into the chat so that we can ask those questions on your behalf. I'm going to start with one that came in during the course of the presentations already. And that's about whether or not there should be some sort of gatekeeping role that we might want to consider for those that are doing retail sales of alcohol, whether that's about having training for people that are selling alcohol, whether it's posting signs or messages maybe in retail locations or even on alcohol packaging themselves with crisis numbers or other information. So it's not a specific question to one of our presenters, it's more a question to the group. So maybe I'll see, Heather, if there's or I'm sorry, Sarah, whether there's something that you may want to comment on with respect to a potential gatekeeping role for those that are doing retail alcohol sales and distribution.
Oh, yeah, thanks, Carla. Actually, if it's okay, I think a couple of the other speakers are probably, their work is a bit better positioned to speak to that, if that's okay.
Sure. So I can open that up, Heather or Norman. I don't know whether you have any comments you'd like to share in that regard.
Heather, you want to go first?
Sure, I can go first because I'll probably be relatively brief. I wouldn't want to speak to gatekeeping role or policies or legislation or regulations, but I would say that I think it's really helpful and useful for anyone who has any sort of a relationship with alcohol, whether they use alcohol, whether they manufacture alcohol or sell alcohol, to really understand just sort of the full range of impacts that it can have. Knowledge is not the only way to prevention, but it is one component. So it certainly would not do any harm, I suspect, and it certainly could be helpful as well. But Norman, I think given your expertise in alcohol policy, you're the right person.
Oh, thank you. I would only add a couple of points. One is that I believe all provinces and territories have a server training programs, which means servers both in bars and restaurants and in liquor stores and wine stores are supposed to be trained to identify people who are intoxicated and they should not be served, or to identify people who are apparently underage. That's the good news. The more challenging news is that what we have found is less effective in private systems than public systems. So in Ontario, for example, my experience, this is anecdotal, but my experience is that the staff of the liquor board are pretty good at doing that part of it. Studies done, for example, comparing in Alberta and I believe in Alberta and BC, found that the employees in the private stores were not as motivated, and I think partly it's because of the profit motive. So I think this could be enhanced. I think there could be signs, warning signs in all places that sell alcohol about various risks associated with it.
That's great. Thank you both for that. There's quite a few questions that have come in in the chat that I'll just sort of summarize, but I think in general there's some questions about whether or not there's any studies or statistics that relate to alcohol use and suicide specifically in First Nations populations. So I'm not sure if there's any work that any of you are familiar with in that area, or if you maybe have any comments on how alcohol use and suicide, the connection may be different perhaps in First Nations than in other populations.
I'll take a crack at it. I think there have been some studies. I came across a few about a few years ago about patterns of use and suicide. I think some of the toxicological studies that you referenced, Heather, I think were based in Indigenous populations. So I think alcohol is a factor in suicides across Canada, but it may be a more intense factor in some populations than others.
And if I can add to that, so I'm working on a project with Inuit Tapiriit Kanatami and looking at data on substance use and suicide among Inuit. And I think broadly there is a gap in terms of having more data sources on both of those and looking at the link among Indigenous populations. There are some unique data sources though, and so we're pulling those together. And from what I've read in the literature so far, there is a link between alcohol use and suicide among Inuit. And at least in Canada, I believe Inuit have the highest rates of suicide. So it's definitely a priority area. And there is some progress that's being made in terms of data sources and data collection among these populations, so that so that there's data that can inform policies and practices.
And hi there, this is Heather. So in the review that we did, there were a few small studies that included some Indigenous populations, but those studies were small, and I think it's really important not to overgeneralize. There's so much diversity and variability even among First Nations communities. The other thing that I really want to emphasize, particularly as a non-Indigenous person, is that absolutely any research looking at the role of alcohol in suicide among Indigenous populations, that research absolutely must be led by Indigenous people themselves, with support from other researchers as appropriate, just to make sure that the research is culturally safe and appropriate. It would be inappropriate for me as a researcher to decide that I wanted to study that population and go out and look for data on it. So just to always keep that in mind when we're wondering about sources of information on specific populations, particularly on ones here in Canada.
That's great. Thanks very much, Heather. I know that your line is cutting out a little bit, in and out, so but I think we did capture that quite clearly, but we'll just ask that you speak extra slowly, I guess, into the microphone with your next comments as well. And thank you to Alain Lessange and others who are posting studies into the chat features, and Sarah, who's posting some links, and Kathy Wheaton as well in La Ronge in Saskatchewan, posting some StatsCan data. So we'll make sure that all of the resources that are being shared in the chat function are summarized for folks as well. And certainly, I should have acknowledged earlier, with so many people on the line, we may not be able to get to all of your questions and comments, but you are welcome to send some information through to us as well, and we'll try to follow up with the speakers afterwards to answer as many of the questions afterwards if we can today as well. So the other topic I've noticed that has come up in the chat has been around access to treatment and the impact that that may have on suicide rates if people are not able to access addiction treatment programs, either because of the current COVID environment or because, sometimes we hear that people are ineligible for programs, as an example, if they have a concurrent mental health condition. So I'm just wondering if you have any comments on that, any of our presenters today, on the degree to which inability to access treatments may be contributing to an increase in suicide rates. Sarah, would you maybe want to kick us off and share your perspective from CCSA?
Oh, sure, Carla. So actually, I was just looking up a link to the What We Heard report, which interviewed people with lived and living experience, and definitely the theme of not having access to services and supports, including harm reduction supports as well, diminished quite a lot during a COVID-19 pandemic. We don't necessarily really know how yet, although, past research as illustrated by Norman suggests that there is a link, but we don't know what the impact of this is going to be on suicide. I guess I would remain optimistic that there's still, there's still an impact that we can have. And I know broadly access to treatment, especially for substance use and addiction, is a gap in most areas of Canada. There is research to show that if you model the need of access to treatment, so the number of people that need certain levels of treatment, and then you look at the actual number of people who can access these services, there is a gap. So I would agree with, I believe there was a lot of comments that this is an area of concern, and I think, there needs to be more focus on improving access to services and supports.
Great, thanks, Sarah. Does anyone else have any comments related to treatment access?
I think it's an important issue. One of the things I highlighted in one of my slides, and it came across a number of reports, is that while work continues on how to improve assessment and screening, it's very challenging, and I think it's because of the nature of suicide. It's not a one thing. It's got all different factors and different conditions and underlying vectors and so on and so forth. So I think it's very difficult to identify with great accuracy an individual who is being seen in a hospital, in an emergency department, or in a clinic, or by a physician, whether he or she is suicidal, or whether they're going to be suicidal in the next week or next month. But I think this is important work, because the better the screening is, the better the assessment is, the more focused the resources can be. I'm not answering your question. I'm just sort of talking indirectly to the topic.
No, that's great. Thanks very much, Norman. I'll maybe ask Norman if you can weigh in on the next topic as well, because I know you touched on the important role that the media can play as well, and we've had a couple of comments in about whether or not we should be doing, I guess, a better job of working with the media and thinking about sort of their responsibilities and their role in cases where they may be glamorizing alcohol use. So I'm wondering, Norman, maybe you want to kick us off with some thoughts on how we might more effectively partner with media.
Well, this is not, I touched on the topic, rightly so, but I haven't done research specifically on the topic, but I have a couple of anecdotal thoughts. And one is, I think in Toronto, each year there are a number of suicides related to subway systems. And for the most part, they are not reported. And I think that's probably a good idea. I mean, the media likes to benefits from sensationalism, but this is unnecessary sensationalism, and I think it just is good to have some real good guidelines. And I think that on this topic, for example, I think there needs to be regular communication between the public health and safety and suicide prevention community and the media leaders to try to figure out what is appropriate to report and what is risky to report.
That's great. Thanks, Norman. And I know certainly that's been an area that the Mental Health Commission of Canada and also Public Health Agency and our partners at CCSA have been working on the mindset guidelines for media that are focusing on mental health. So I think that's certainly an important area. So we're coming up to the close of our session today, and I'd like to say a big thank you to Heather, Sarah, Rob, and Norman who have joined us and shared their expertise with us today. I want to thank everyone who has dialed in to join us today as well for all of your questions, your comments, and all the fantastic resources that you've all been sharing in the chat feature as well. I know that we haven't had a chance to get to all of the questions. We'll be posting in the chat a mechanism for you to email any additional questions that you have to Haley White at the Mental Health Commission, and she'll be working with us behind the scenes to loop back with our presenters to ensure that we can answer as many of those as possible and send them back out to you along with the presentation slides from as well. So thank you all so much for that. I'd like also to say a big thank you to our partners at the Canadian Foundation for Healthcare Improvement who have been helping us behind the scenes today and with the technology platform. It's wonderful to have had their support today, as well as the fantastic support that's been provided by our staff at the Mental Health Commission of Canada as well. So that concludes our webinar for today. We will be having a couple of very short poll questions that are going to come up on the screen as well. Your feedback is really important to us as we plan for our future webinar series. So we'll ask you the first question that should be now on your screen, which is to rate your own knowledge about today's topic, where 1 is that you're very new to the topic, and number 2, 3, and then 4, meaning that you're quite knowledgeable about the topic. So we'll have you just quickly answer that poll question about your knowledge coming into today's webinar. We have just 3 short questions for you today. So the second question is rate your knowledge about today's topic after having participated in today's session, and we'll ask you to use the same rating scale, 1 where you're new to the topic, all the way to number 4, meaning you were quite knowledgeable about the topic. And then the last poll question that we have, the third one that should be on your screen now, is just to indicate your agreement with the following statements. You learned something new in this presentation, you learned something that you can apply to your own suicide prevention work, and the presentation was effective and applicable to your work, and we'll just have you check all that apply based on your experience today. So I hope we've given everyone some food for thought this afternoon. Again, our sincere thanks to all of our presenters for the time that they dedicated to the presentation today and all of their work in the lead up to the session. And again, thank you all so much, all of you who joined us from all across the country, from coast to coast to coast, and those who participated in our French language session as well. And bon, merci à vous aussi. So thank you all so much for joining us, including some of our international guests who have joined us from a number of countries, and our colleagues in Belgium, en Belgique aussi. Merci, bienvenue. Thank you all so much for joining. We wish you a wonderful rest of the day and hope to see you again at one of our future webinars focused on suicide prevention. So on behalf of all of us at the Mental Health Commission of Canada, sincere thank you and a great rest of the day.
This concludes today's webinar. Thank you, everyone. You may now disconnect.